Hello, my name is Siddharth Kurkure. I'm a transitional year resident at St. Agnes Medical Center, and I made a presentation about late life depression. So, late life depression can be characterized as either patients who have had depression earlier in life and then they're now aging 65 or older, or it could be their first presentation of depressive symptoms later on in life. But there's a very significant disease burden, and I'll talk a bit more about the details of it. But patients who are older have a much higher mortality risk if they have depression. Their mortality risk from all causes goes up, and risk of certain conditions is higher, and there's a lot of other comorbidities. And a lot of patients who have dementia also have concomitant depression. So that's why I think this is a very important topic. But I'm just going to start off by talking about depressive disorders. DSM-5 characterizes them as the presence of sad, empty, or irritable mood, accompanied by somatic and cognitive changes that significantly affect the individual's capacity to function. So there's many different versions, but DSM-5 discusses disruptive mood dysregulation disorder. That's severe persistent irritability in children ages 6 to 18. Premenstrual dysphoric disorder, that's mood lability, a labile mood, more irritable, dysphoria, anxiety, repeatedly occurring around menstruation. So those two are outside of the scope of this presentation, but those tend to occur in younger populations. Major depressive order disorder, so the difference between major depressive disorder and persistent depressive disorder is that persistent depressive disorder, typically you don't have to meet as much of the criteria, but for major depression, but it has to be present for 2 years. Major depressive disorder, it's at least 2 weeks. And then I think I was reading in DSM-5 where patients can have both concomitant persistent depressive disorder and major depressive disorder if their major depression lasts more than 2 years. Their depression can be induced by certain substances as well as medications, and other medical conditions are commonly implicated in causing major depression. So, we're going to start out with major depressive disorder. So, it's the five Siggy Caps criteria. So that's a depressed mood most of the days, nearly every day. That can be either subjective or objective. There's markedly diminished interest or pleasure in all or almost all activities most of the days, most of the day, most more often than not. Appetite changes that frequently occur. Maybe there's significant weight loss if they aren't trying to lose weight, or weight gain if they're not trying to gain weight. In children, failure to thrive or even failure to gain weight as expected is part of the differential. Or sorry, not the differential, part of the evaluation. Either they've had sleep disturbances or they're sleeping too much. Psychomotor agitation or retardation. DSM-5 reports this as being observable by others, and it's not merely subjective feelings of restlessness or being slowed down, but so during the interview, you notice that a patient might be shaking their legs more or reaching to something. It's fine, it's taking them longer. That's typically what DSM-5 is trying to get here. Fatigue or loss of energy, feelings of worthlessness, excessive or inappropriate guilt nearly every day. Um, it's not just self-reproach or being guilty about being sick, but maybe, for example, you feel like you still feel really guilty about maybe not treating a relative with as much respect as you wanted, and now they're gone, and you feel like you're responsible for their death. And then recurrent thoughts of death, not just the fear of dying, but thoughts about dying, feelings that they would be better off dead, recurrent suicidal ideation without a plan, or a suicide attempt, or a specific plan for committing suicide. Persistent depressive disorder, typically it's a depressed mood for most of the day, still. for at least 2 years. And then while depressed, appetite changes, sleep changes, energy, low self-esteem, concentration, and then feelings of hopelessness. That's two of those criteria for persistent depressive disorder. And it's 1 year for children or adolescents. And then criteria for a major depressive disorder may continuously be present for 2 years. So they could have concomitant episodes. There's never had any mania or hypomania because that would be bipolar or cyclothymic. And then disturbance, it's not explained by schizoaffective disorder, schizophrenia, delusional disorder, other types of psychosis. It's not attributable to the effects of a substance or another medical condition, and it's got to cause significant distress or impairment in social, occupational, or other areas of function. So, for substance or medication-induced depressive disorder, so in this case, the diagnostic criteria has to be it's not better explained by a depressive disorder that's not medication or use. So think about it like it develops during or soon after substance intoxication or withdrawal or after exposure to a medication. It's capable of producing the symptoms, and it doesn't occur the disturbance doesn't occur exclusively during delirium. So if it precedes the use of a medication or whatever, it's probably more likely major depressive disorder rather than substance or medication induced. And then there's other medical conditions like depressive disorder. I apologize, there's a typo. It's actually depressive disorder due to another medical condition. But on USMLE exams, I've seen major depressive disorder due to another medical condition. So here it's based off of a medical condition. So hypothyroidism is really common, anemia is really common, so things like that. And it's not, again, not occurring exclusively during delirium. Late life depression, as I mentioned, has a very significant disease burden. So it could be older patients when depressions present, they had depression earlier in life, or they've had new onset depression later on in their life. So this is very underdiagnosed, especially in Black men and Latino men. Prevalence in age is in people above 65, it's almost 15%. So there's 4% who had major depression and then 10% minor depression. And Up to Date had a really nice figure about how often this coexists with other comorbidities. So in community focused settings, it's 2%, but as opposed to the general adult population. But in the chronically ill, there's almost 10%, well upwards of 30% for either hospitalized patients and especially geriatric inpatients. Cancer outpatients versus inpatients in the 30s. After a stroke and myocardial infarction, it's the most. And then Parkinson's is the third most. So there's a very significant comorbidity burden and it raises the risk of mortality. I think the incidence might be incidence, which is based off of percentage of people or rates of new cases each year among people who have previously been unexposed. So in the Netherlands, there was a study they followed for 8 years with incidence of depressive symptoms. It was 7 per 1,000 person years. There's limited epidemiologic studies that have talked about patients above the age of 80, so the true incidence might be underestimated. And then it's estimated that the recurrence rate could be 25 and a half per 1,000 person years. Part of the One way we can help better address late life depression is that we need every geriatric patient needs a comprehensive geriatric assessment. So functional capacity, frailty, fall risk, cognition, mood, polypharmacy, social support, financial concerns, goals of care, and advanced care preferences. Other important things to evaluate are nutrition changes, weight changes, urinary or bowel incontinence, sexual function or dysfunction, vision and hearing, dentition, their living situation, and spirituality. Those are all factors that can contribute to late life depression. And typically there's five different models that have been evaluated. I won't get into that just because that's a lot of very general geriatrics, but that's a home geriatric assessment, acute geriatric care units, post-hospital discharge, outpatient consultation, and inpatient consultation. Proposed mechanisms of late life depression, again, estimated to be multifactorial, like most things in psychiatry, like biochemical abnormalities, beta amyloid and tau, which is also observed in Alzheimer's, genetic factors, neuroimmune dysregulation, neuroinflammation. But most of the literature that I've reviewed seem to come back to cerebrovascular disease. Yes, there's cerebral atrophy, subcortical deep white matter, and paraventricular ischemic lesions, decreased brain volumes, and there have been genetics implicated. And while historically it's been understood that later in life depression may be less genetic components, less common, actually, recent studies have found that there's actually some familial and genetic loading for vascular disease. So genetic predis history of a family history of stroke or chronic ischemia to the brain, that actually can microischemia, that can actually raise the risk of depression. There have been several studies that have been pooled. There was a study with 43,000. 9,000 of them had depression. There were 48 studies. Most of them were cross-sectional. So there were higher levels of intercellular adhesion molecule 1 in patients who had depression. And then there have been increased severity of white matter hyperintensities, including cerebral small vessel disease in patients with depression. And then there were prospective studies that followed individuals without depression at baseline. The new onset of depressive symptoms was more common in severe white matter hyperintensities. And so these are all statistically significant if you're studying for USMLE exams, understanding that confidence intervals are greater than one. So we can all tell and the odds ratios are all greater than one. So definitely, like definitely there's some biochemical markers and then imaging markers that can be seen. Depression can be the initial manifestation of neurodegeneration or vascular dementia. There's a lot of risk factors for late life depression that are common in older adults. Females, social isolation, for example, a study of 600,000 nursing home residents that were 65 and older, over half of them became diagnosed with depression by a physician within their first year of admission. Widowed, divorced, or separated marital status contributes, lower socioeconomic status contributes, comorbid medical conditions is another huge factor. A lot of older patients have chronic diseases, especially strokes. So when cerebrovascular disease, a history of cerebrovascular disease is implicated, there's post-stroke depression. So that's after an ischemic stroke. But then there's vascular depression as well. And that's typically what we see along with vascular dementia as well, where it's not large strokes, but it's chronic ischemic changes, uncontrolled pain. Older patients tend to have pain that's chronic and harder to control, and a lot of older patients tend to have sleep disturbances, insomnia, functional impairment and cognitive impairment are commonly seen in this population as well, and that those are major contributors. Persistence of sleep disturbances have been associated with persistence or recurrence of depression. There's a lot of comorbidities as well that are associated with depression in older adults, and these raise the risk of mortality. Conversely, these conditions will improve if the depression is treated. So after a myocardial infarction or a stroke, it could be 3 to 4 times the mortality risk. Like they're 3 to 4 more times likely to die than afterward. Admission to SNF or a residential care facility, if depression is present at the time of admission, that increases the risk of death within a year. And both medical major depressive disorder and a past medical history of depression, major depressive disorder, independently predicted in hospital death after control, even after controlling for illness severity. Dementia, so depression could be the prodromal stage of dementia, but it could also be an independent risk factor for dementia. Suicide, older patients attempt it less often, but they have a higher rate of completion. And males over the age of 85 have the highest rate. This is typically associated with comorbid medical illness, chronic and inadequately treated pain, terminal illness or worsening of their physical illness, maybe if they've had widowed or social isolation, a history of personality disorders. But on a USMLE exam, if they've had a prior history, always pick that answer as being their biggest risk factor. But if you're in the clinical setting, that also is their biggest risk factor, but you have to think about all of these other things. Other psychiatric comorbidities that can include substance use as well as alcohol, hypnotic medications because maybe they're falling asleep, so they need more to fall asleep. Prescription medication. We see this a lot with opiates and other pain control medications because patients have so much pain, and then there might be some dependence, and then anxiety is also implicated. Depression and dementia are risk factors for each other. There was a meta-analysis of several community-based observational studies with about 50,000 patients who didn't have dementia at baseline. The risk of dementia, especially Alzheimer's and vascular dementia, was higher in patients with depression. Even when adjusting for confounders, the risk ratio was 1.6 with a 95% confidence interval, 1.4 to 1.8. These have also been reflected in retrospective studies, especially Alzheimer's and vascular. These are independent risk factors. So there was a there was a population-based cohort study in Sweden. The rates of new onset depression were higher in those with Alzheimer's compared to those without dementia, even after adjusting for potential confounders. I think it was the hazard ratio is 2.2 in women and then 2.7 in men. Making the screening or diagnosis. So PHQ-2, that's the two-step. That has good sensitivity. The specificity is about 70%. Sensitivity is 90%. PHQ-9, so 14 studies have showed a pooled sensitivity and specificity. Sensitivity is 83%, specificity is 86%. The Cornell scale for depression and dementia and the geriatric depression scale are also screening tools that have been developed. Still, it's a very challenging diagnosis to make in this population. So need to look hard. You need to ask about mood or somatic symptoms out of proportion to what they've expected, poor response to standard medical treatment. Maybe their motivation to participate in treatments has been declining. They haven't been engaging with care providers as much. A dysphoric mood may be less reliable in patients above the age of 85. So then it's more focused on changes in the mood or their interest, non-physical symptoms, social withdrawal, while using physical symptoms to support the diagnosis. Another thing that's really helpful is that patients sometimes they might show their family member will show affection, but if they don't respond well to it, then that's something that can clue you in for the diagnosis. So the differential diagnosis is very wide, and I should have also mentioned that due to substance slash medication or another medical condition, because this is another nice table from up to date. So alcohol, beta blockers, cannabis, opiates, steroids, withdrawal from cocaine or amphetamines, barbiturates, acetylcholinesterase inhibitors, certain chemotherapy agents, and lead are major factors that can contribute. Hypothyroidism is the one that commonly shows up on USMLE exams as well as in clinical practice, but also hyperthyroidism can be implicated. Like that could be causing depression due to a medical condition. Cushing's syndrome, meaning like, or adrenal insufficiency, hyperparathyroidism, hypopituitarism, metabolic derangements, so vitamin B12 deficiency. A lot of older patients will have anemia, likely iron deficiency anemia because of GI bleeding from colorectal polyps, but or diverticulosis and whatever. But there could be anemia from other causes like vitamin B12 deficiency, chronic disease, things like that. Wernicke-Korsakoff syndrome is commonly implicated if patients have had a significant history of alcohol intake. Infectious disease can be incorporated, HIV, typically seen in certain acute infections as well, pneumonia, but there's chronic infections as well, like tuberculosis, EBV, and then neurosyphilis. Alzheimer's disease, Parkinson's disease, Huntington's disease might present a little earlier in life, but that's also associated. And then patients typically won't have a new diagnosis of multiple sclerosis this late in life, but they they might have been diagnosed earlier in life and then they've had relapses and new exacerbations that could be contributing. They could have subdural hematoma. It's a very common problem in older patients because bridging veins are weaker, or sorry, no, it's easier to damage the bridging veins because their brain size has shrunk. Normal pressure hydrocephalus, strokes, post-traumatic brain injuries, brain tumors, malignancy, especially in the pancreas, lung, and breast. Lupus, again, might not present at that time, but certainly exacerbations in patients who are diagnosed earlier in age. Other vascular disorders. Congestive heart failure has similar symptoms as well. And then other chronic inflammatory diseases. The basic approach to treatment always start, are they a threat to themselves or are they a threat to others? So if they have a plan to hurt themselves or kill themselves, that's active suicidal ideation. It requires immediate psychiatric management. If they express psychotic symptoms of hopelessness, insomnia, and malnutrition, that should be addressed. Look at their medication list and possible substances. Medical management's important. If they've had history of prior depressive episodes, the age that they've had it, prior pharmacotherapy that have been done, length of prior remission if achieved. What do they have a family history of depression, or do they have a family history of strokes or other neurological conditions? Would they benefit the most from psychotherapy, medications, or electroconvulsive therapy? So this is kind of small, so I apologize. I'll zoom in a little, but there have been, oops, I'm sorry. Oops, nope. So there have been some psychotherapies that have been established for major depressive disorder, cognitive behavioral therapy. So challenge the inaccurate negative thoughts and beliefs and problematic behaviors. This typically is considered gold standard. Interpersonal psychotherapy, that's interpersonal difficulties in either grief, role disputes, role transitions, or general interpersonal deficits. Problem solving therapy, that's for rational and effective problem solving skills. Behavioral activation, that's to identify precursors and consequences of problematic behaviors, changing problematic behaviors. Family or couples therapy, so that correcting distorted communication, addressing impaired relationships. Short-term psychodynamic psychotherapy, that's to improve patients' awareness and insight regarding repetitive interpersonal and intrapsychic conflicts. And supportive psychotherapy, typically that's like validation, active listening, reassurance, and then support for addressing the personal problems. Psychotherapy is underutilized in older patients. CBT is typically considered the gold standard and it's the best studied. Problem-solving therapy, so multiple studies have demonstrated superiority of problem-solving therapy over supportive therapy. And then supportive therapy, that's just the emotional support and validation. Life review therapy, they can reflect on, evaluate, and integrate life experiences. Medications for late life depressions, they might be reluctant to pursue medications. They might fear becoming dependent on the medication. Maybe there's some cultural or societal perspectives on just depression. There's the belief that meds may inhibit a normal emotional reaction. They might have had bad experiences with that antidepressants or with other medications as well. Like none of this is unique to depression. Polypharmacy, they're concerned that they're taking too many meds, things like that. Do you do tricyclic antidepressant or selective serotonin reuptake inhibitor? 26 randomized trials of patients with depression ages 55 and older found comparable efficacy between the different antidepressant classes. There were higher withdrawals due to side effects in tricyclics. And for those of you studying for exam or for USMLE exams, they like to test the anticholinergic, antihistamine, and antiadrenergic effects of tricyclics. Monotherapy is preferred. So the start out dosing is typically half than that of younger patients, just to account for decreased excretion or metabolism or decreased excretion of the drug. But you still need to reach the same therapeutic range, so they need follow-ups, and then they need to be up titrated if needed. It can take up to 16 weeks to feel the full effect of the antidepressant. Usually it's 8 compared to 4 to 6 for younger populations. However, some studies have found that if patients don't improve by 4 weeks, they're unlikely to respond after 8 weeks, and they might be candidates to change their treatment plan earlier. The duration typically aimed 6 to 12 months after achieving remission. Maintenance therapy is given to prevent relapse. What I found that was interesting is that psychotherapy as maintenance therapy doesn't confer a benefit. And there was a study over 2 years, interpersonal psychotherapy didn't prevent recurrence. How discon Patients may be more willing to discontinue or switch antidepressants just because they're taking a lot of other medications. So they could have more drug-drug interactions, or they might feel the effects of side effects more. So again, I apologize. Table is not easy to read, but commonly used medication. So SSRIs, there is some risk of QT prolongation. So maybe an EKG, a baseline EKG would be helpful. Careful if they have additional QT prolonging medications, but paroxetine may be weakly anticholinergic, but less so. And then paroxetine requires the taper more than most of the others just because they have more severe discontinuation symptoms. Escitalopram typically is the best tolerated. It's not sedating. There's the low risk of sleep disturbance, and there's fewer drug-drug interactions. Sertraline is also a good. Sertraline's also really well tolerated. It's not sedating. There's a lower risk of insomnia, and then there's not a lot of cardiovascular effects, but they have more frequent GI symptoms. Fluoxetine is more activating, so typically that might be more helpful for patients with lower energy. It has a longer half-life, so tapering upon discontinuation is less important. Um, so SNRIs, these inhibit both serotonin and norepinephrine reuptake. So venlafaxine is activating. It may cause dose-dependent increases in blood pressure. And the activating effect might be useful if patients have lower energy. These are also SNRIs are also useful in patients who have comorbid pain, especially neuropathic pain. A lot of older patients, I've seen this on their list just because they've had diabetic neuropathy, so that's useful. Duloxetine is really useful for peripheral neuropathy, but because there's more drug-drug interactions, yeah, you have to be more careful. And then levomilnacipran may cause dose-dependent urinary hesitancy or erectile dysfunction. It's typically well tolerated, but may also have some cardiovascular effects too. Atypicals, mirtazapine. So this is associated with so mirtazapine, this is the prolonged half-life. They have active metabolites. It's associated with drowsiness, and then there's rare reports of agranulocytosis. There's a lower risk of sexual dysfunction. And if older patients tend to be underweight, so it's it's really useful for stimulating their appetite. Some of them might be on mirtazapine even if they don't have depression. Bupropion, the thing with bupropion is that any patient who has a history of agitation, they have a history of seizures or eating disorders, very commonly tested on USMLE exams, by the way, that needs to be avoided. But bupropion typically it has a stimulant effect. It's useful for patients with low energy and apathy. There's a dopaminergic action, so it's a little bit helpful for patients with comorbid Parkinson's. But bupropion's not the best choice in patients who have poorly controlled hypertension, just because there's a dose-dependent increase in diastolic blood pressure. Vilazodone, you have to take with food to improve its bioavailability. There's a lot of drug-drug interactions through the CYP3A4 system, but there's lower incidence of weight gain or sexual dysfunction, but typically its role in therapy is not yet defined. Trazodone. So this is not used as often. This is sometimes used as an adjunct to an SSRI for insomnia. It's not usually used as monotherapy. Associated with orthostatic hypotension. There have been some reports of hyponatremia. And if you're a medical student studying for exams, you need to know the most commonly tested side effect is painful ischemic priapism, and the treatment is injection of phenylephrine into I think it's the corpus cavernosum. Tricyclics, typically these might be poorly tolerated by older patients because they have anticholinergic effects, they have antihistaminergic effects, and they have anti-adrenergic effects. Nortriptyline typically is somewhat sedating, can be useful if they have anxious depression and they haven't responded with first or second line antidepressants. Desipramine, typically mild stimulating effects for patients with lower energy if they haven't responded to first or second line antidepressants. And for USMLE exams, you need to know the fact that these are cardiotoxic, and this is because it's because of sodium channel toxicity. That's so it destabilizes cardiac myocyte membrane. So treatment for that, it's sodium bicarb. The bicarb actually isn't helpful, but by giving supplemental sodium, it's best given with bicarb for whatever reason. That helps stabilize the cardiac membranes. Adjunct, so quetiapine monotherapy, that's actually not really an adjunct, but it's typically not considered first or second line. Some studies have demonstrated benefit, but there's concerns for sedation, dry mouth, extrapyramidal symptoms. Literature hasn't shown literature does hasn't shown us anything that would cause us to recommend this over or SNRIs. Methylphenidate. So now we're going more into the adjunctives. Methylphenidate's a stimulant medication. So there was a 16-week randomized trial. Patients with major depression who were free of psychotropic meds for 2 weeks, they were assigned to receive citalopram plus methylphenidate, citalopram plus placebo, or methylphenidate plus placebo. So the combination treatment was more effective. They improved more quickly. and discontinuation due to side effects appear to be comparable for the three groups. Aripiprazole may have some benefit in treatment-resistant depression. So there was a 12-week trial in which there was aripiprazole was added to venlafaxine treatment that was refractory to venlafaxine. So there was improved remission, but they had more akathisia, Parkinsonism, and weight gain, which are known side effects of aripiprazole. There was another 10-week trial done subsequently to depression refractory to an average of two regimens. There were two groups. There was an aripiprazole group as an add-on or extended release bupropion. Excuse me. And then not only was there a greater benefit magnitude, but there was also more side effects in aripiprazole. Cholinesterase inhibitors has shown benefit in patients with Alzheimer's disease, but not as much of a clear benefit noted in the literature for late life depression. It was associated with improved cognitive functioning at 1 year, but not at 2 years. And then there was also an increased risk of recurrence. Neurostimulation, so electroconvulsive therapy is usually done for life-threatening depression or significant impairment. It's a very safe procedure, but seems like cardiopulmonary causes are the highest cause of mortality. There's risks of fractures, aspiration pneumonia, headache, vomiting, tooth or tongue injury, and then fasciculations. What bothers patients the most are retrograde amnesia. So it's worse with public or world events, less commonly to self, but it takes longer to resolve than anterograde amnesia. Anterograde amnesia, it's usually transient. Retrograde is usually transient as well, but it takes longer to resolve. And then there's also acute confusion. There are other modalities that have been explored, but there haven't been any randomized trials that have demonstrated the benefit of these modalities in older adults. I am going to talk about repetitive transcranial magnetic stimulation. So typically that's an alternating electric current placed against the scalp. We're trying to generate alternating magnetic fields. And that goal is to create electric currents that induce depolarization of neurons in specific areas of the surface cortex. There have been studies that have shown superiority over placebo, but there have been low absolute rates of remission in certain studies. So, in patients who haven't responded to adequate antidepressant therapy, add-on treatment with repetitive TMS is efficacious in many studies. Other interventions, exercise programs, in general, you do want to do, in general, that's something that we like to tell our older patients to do anyway because they need to keep up some cardiovascular conditioning and then loading their bones to minimize fracture risk. Bright light therapy is helpful. And then there are system level interventions. There's collaborations like non-physician mental health professionals or depression care managers will integrate their psychiatric and primary care, and then they'll add the psychological or psychosocial interventions. There's home-based care as well, and then there's family support. So these are my references. Thank you so much for this. And as a very like I've said, late life depression has a very significant disease burden. And yeah, when selecting a treatment, you have to take into account drug-drug interactions and the fact that they may not tolerate it as well as somebody younger. So thanks again.